There we go. So welcome everybody to the Smoking Cessation Service introductory webinar for the service focused on the Wirral, although a lot of tonight will be relevant wherever you're watching it from for the Smoking Cessation Service in Cheshire Merseyside. We will cover a broader update on what's going on around the area, but tonight we are focusing on what's happening with Wirral University teaching hospitals and going live. So just to give you an idea of what you're going to be hearing tonight, so my name's Adam Irvin. I'm the Chief Exec of Community Pharmacy Cheshire and Wirral. So I'm going to be introducing the session. I'll also play a little bit of a host role when it comes to Q&As. I'll then hand over to Jan Ward from Midlands and Lancs CSU. Jan's in charge of implementing the service at the regional level and will give us an update on that side of things. We'll then have Saf from ABL talking about the Wirral service, and then Gary from Community Pharmacy Cheshire and Wirral talking around the PharmOutcomes side of things. In terms of how tonight's working, you might be a bit confused as to why you don't see yourself on the screen. We are actually doing this as a webinar rather than a meeting, so it's a bit different to a normal Zoom meeting. It is just a webinar, so the presenters are the ones that are allowed on screen and can talk. And you'll probably see our cameras all go off when we're not talking. So we're all on at the moment. Whoever's running that certain section will keep their camera on and the rest of us will disappear just so we don't distract you. There is both a Q&A and a chat function. I'd really encourage you, if you do have any questions, just to put them in the Q&A function. Some of them, if they're very, very specific, we can answer there and then, and the rest we'll save up and we'll do a Q&A response at the end. If there is anything we can't answer today, we will take it away and get back to you. You will have had the warning when you started that we're recording this session. The purpose we're recording this for is we host these up on our website, so other contractors in the area, if they want to know the details of their local service, or they want to at a later date join in and they've decided not to go to start with, but they want to join in, then they've got this as a valuable resource over time to look back on. So in terms of where we are, the Community Pharmacy England resources, I'm gradually getting used to calling it that rather than PSNC, they're all there and they're available. The place to get them from is from the CPE website. It's under National Pharmacy Services and the Smoking Cessation Service. There's some really good stuff on there, particularly I've highlighted there the good guidance as well as the contractor checklist, so that both contractors and their teams can go through that and make sure that they're ready to go. A lot of the sign-up protocols, and I think the people, just looking at the people on the call, I think most of you live have got this protocol sorted out as far as I'm aware, but the equipment needs as well as the training requirements need to be done before you sign off. So for those watching, make sure you go through that checklist and make sure you follow that. It's really helpful as you're going to go live is to link in the timeline with the hospitals local to you. Obviously, we're going to hear a lot about the Wirral's timeline and when they're aiming to go live in the journey they've been on tonight. But if you're on a border and you've got a couple of hospitals nearby, make sure you find out A, how they're going to be running their referrals, but B, when they're going to be both introducing it to start with and then ramping it up depending what their plans are. And we'll try and host and facilitate that information as we go through. So I think that's about enough from me as an introduction. First of all, I'm going to hand over to Jan from the Midlands and Lancs CSU. I'll let Jan introduce herself and her background, and I'm going to turn my camera and microphone off just so that you can focus on Jan and what she's saying. So I hope it goes well, and like I say, use the Q&A function for anything that comes up.
Thank you, Adam. Good evening, everybody. My name is Jan Ward. I'm a pharmacist at Midlands and Lancashire CSU. So the CSU is being commissioned by NHS England to support the implementation of the Smoking Cessation Service. So I am part of the implementation team, and I am the point of contact for the Northwest region. I'm here tonight with my colleague, Steve King, who is in charge of a few areas, including Southwest and Southeast of England. Could I have the next slide, please? So tonight, I'm going to give you a background on the Smoking Cessation Service. Then I'm going to talk about the pilots whose findings were used to commission the National Smoking Cessation Service. And then I'm going to give you an update on the implementation of the service. And at the end, myself and Steve are happy to take any questions. Can I have the next slide, please? So I'm sure you're all aware of the NHS long-term plan, which focuses on improving prevention of avoidable illness. We all know that smoking is one of the biggest avoidable cause of illness and premature death. So treating tobacco dependency is specifically identified as a key intervention to preventing avoidable illness. So prevention is a core component of the NHS long-term plan, which sets out commitment for the NHS in tackling tobacco dependence. It states by 2023-24, all people admitted to hospital who smoke will be offered NHS-funded tobacco treatment services. And this includes acute, maternity, mental health services. The commitments are designed to be the NHS's contribution to helping deliver a smoke-free generation, to build on the good work already being delivered, and to complement current stop smoking services, focusing on both physical and mental health services, and to introduce a level of national direction, but with local development and delivery. Can I have the next slide, please? So previously, we've had smoking cessation services in primary care, but the involvement of community pharmacy has been variable. We all know that hospitals across England are adopting the Ottawa model for smoking cessation in order to support the delivery of the NHS long-term plan. For those who are not familiar with Ottawa model for smoking cessation, it involved the systematic identification of active smokers when admitted to hospital. And this is followed by brief advice and individualized bedside counseling, timely NRT or pharmacotherapy, and then the patient is followed up after discharge. So it is a 12-week program, and it's been proven to increase the one-year quit rate by 11%. It's also, when implemented fully, it's expected to save the NHS 85 million within 1 year. So that's a considerable cost saving to the NHS. The aim of the Smoking Cessation Service is to support delivery of the prevention ambitions in the NHS long-term plan, and for community pharmacy to become a nationally available choice for patients to access smoking cessation support post-discharge. Could I have the next slide, please? So the Smoking Cessation Service is an advanced community pharmacy service, and which follows on from the Smoking Cessation Transfer of Care pilots, which started in October 2020. With the first pilot site being the Royal Oldham Hospital, which made referrals to 12 pharmacies in the Oldham area. The pharmacies were selected following an expression of interest process, and it was important that they gave good geographical cover, and also they had extended opening hours. There was also a second pilot site that went live in November 2021, working with Guy's and St. Thomas's Hospital and King's College Hospital. The data from the pilot has been used to inform what the nationally commissioned service would look like. And the pilot sites have now transitioned into the Smoking Cessation Service. Thank you. So what was the findings? So this is the findings from the Oldham pilot, which took place October 2020 to December 2021. And there were 201 patients referred to the service, 81 patients enrolled in the service, and this equates to a conversion rate of 40%. And this is actually in line with the numbers that we're seeing being referred into the locally commissioned service. The 4-week quit rate was 57%, which is a really good outcome. and it was actually slightly higher than the locally commissioned service. And 19 patients completed the 12-week program. And that equates to a 12-week quit rate of 23%. I should also mention that 41% of patients recording a quit at 4 weeks went on to record a quit at 12 weeks. So these successful findings of the pilot demonstrate that community pharmacy is well equipped to deliver on outcomes just as well as a locally commissioned service. Could I have the next slide, please? So following the successful findings of the pilot transitioned into the Smoking Cessation Service. And this led to a bespoke standard treatment program being developed with the NCSCT, and service funding was agreed. And so the consultation fees are paid nationally from the Community Pharmacy Contractual Framework, whereas NRT costs are charged back to the ICB, and the fees come from the primary care indicative prescribing budget. There was also a service specification that was agreed, and recently you might be aware that that has been updated to include the key change there is technicians as well as pharmacists can now provide the service. And thank you. So, and the service was launched to coincide with the National No Smoking Day on the 10th of March last year, with pharmacy registrations opening on the 1st of March 2022. The launch of the service was an intentional soft launch, and this was really taking into account that trusts were at different stages in implementing or setting up their inpatient tobacco dependency services. Could I have the next slide, please? Thank you. So I mentioned earlier that the CSU has been commissioned by NHS England to support the implementation of the Smoking Cessation Service. So our role is scoping and mapping, and this involves understanding the exact position of each acute trust in terms of their delivery of the relevant parts of the NHS long-term plan. Our role is also to inform planning, to identify key stakeholders to support working groups. We also facilitate implementation of the service at local level. Advisors such as myself are available for each region. So I mentioned I'm the point of contact for the Northwest region. And we're here to ensure pilot sites transition successfully, to engage with early implementers and those sites looking to start delivery imminently. Our team has also produced supporting documents and promotional material. So what is the process for a trust going live with the Smoking Cessation Service? Well, there's 3 stages to the process. So stage 1, as I mentioned, scoping and mapping, and this is where our team would try and identify and contact the key people at the acute trust, and also to set up those early engagement meetings to try and understand the baseline position of the trust in terms of setting up their inpatient tobacco dependency service. And once the trust has shown an intention to implement the Smoking Cessation Service, then it's important that we have the right sort of people around the table. So key stakeholders, they would include OHID, and OHID stands for Office for Health Improvement and Disparity, Public Health, LPC, of course the Acute Trust, and representative from the locally commissioned service where one is available. And then we move on to stage 2. In this stage, then we try to understand and agree on a referral pathway. and a method for sending a digital referral. So once we've got our referral mechanism agreed and the trust has also agreed on a go live date, then we move on to stage 3. And this is why we're here tonight. It is very important that we engage with yourselves and that we've got good sign up. So we have good geographical coverage. And for the pharmacies that are registered to provide the service, that they are service ready. And where we don't have such good geographical cover, then we would seek the support of the LPC. Could I have the next slide, please? Thank you. In terms of the referral pathway, so just briefly, we have a hospital inpatient undertaking a supported quit attempt. So upon discharge, there will be a discussion with the tobacco dependency advisor. And the patient will be given a choice on how they want to continue their smoking cessation treatment, whether it's with the locally commissioned service or the community pharmacy smoking cessation service, or the patient may opt for self-care. But it is important that the referral is equitable. Could I have the next slide, please? So this is the model of care taken from the original service spec. So you might be familiar with it, but just briefly, in the red, step 1, we have a patient admitted who is identified as a smoker. So step 2, with the patient's consent, tobacco dependency treatment is initiated. And step 3, we move on the transfer of care. So upon discharge, the patient will choose a registered pharmacy of their choice where they can continue their smoking cessation treatment. And step 4, so when after the patient's been discharged, a referral is sent to that pharmacy. And step 5, it is important that the pharmacist or the technician, they act on that referral within 5 working days, and that is in line with the service specification. And you have to make 3 attempts to contact the patient, and the 3rd attempt has to be on the 5th working day, and that's really to ensure that the patient doesn't run out of their NRT. So once you've made contact with the patient and the patient has consented to enrolled in the smoking cessation program, then they transition into the service. And at this point, then you would make, with the patient, of course, agree on an appointment cycle. And it is important that appointment cycle overlaps with NRT supplies so that the patient doesn't run out. And finally, step 7, post-event messaging. You are required to provide patient-level outcome data to the referring trust as well as the patient GP. Could I have the next slide, please? In terms of training, so you need to have undertaken the NCSCT Stop Smoking Practitioner certification. If you've already completed this, then you do not need to repeat it. And once you are a stop smoking practitioner, then you will need to undertake additional modules in order to support pregnant women and people with mental health problems, as well as patients who use e-cigarettes. It is also very important that you have read the bespoke standard treatment program that I mentioned before, and this just gives you a more structured approach to your consultation. It is also very important that you're competent at undertaking carbon monoxide monitoring, and also you have read the SOP for the service provision. Could I have the next? Thank you. So just an overview. So the smoking cessation service is intended to complement existing locally commissioned services. It does not replace a locally commissioned service, and it's to provide additional capacity and more choice to the patient. And you can only see patients that have been referred from the acute trust who wish to initiate or continue their quit attempt post-discharge. You need to make contact within 5 working days of receiving a referral. And as I previously mentioned, you need to make at least 3 attempts to contact the patient. If no contact has been made, then you need to inform the referring trust before you close that referral off. And I mentioned the pharmacists will provide up to 12 weeks support. So if the patient, for some reason, maybe due to an extended hospital stay, had maybe a week support, then pharmacies can only give 11 weeks support. So that's important. Consultations, which have to, in line with the specification, at least every fortnightly, can be delivered face-to-face or remotely. And you can make NRT supply up to 2 weeks supply at a time. And there is also an approved list of NRT products in the current drug tariff. Could I have the next slide, please? Clinical record has to be made on all activities pertaining to the service. And carbon monoxide monitoring has to be undertaken for face-to-face consultation. It's just a good way to validate the self-reported abstinence from a patient. There is no charges for NRT supplied, even if the patient pays for prescriptions. And you are required to provide patient-level outcome data to the referring trust, as well as the patient's GP. And the information required is all in the service specification. And in terms of fees, there's a £1,000 setup fee and £30 for the initial consultation, £10 for interim consultation, £40 for the last consultation, which can take place anytime from week 4 to week 12. And you need to make your claims each month via the NHS BSA Manage Your Service portal. So update, in terms of trust status, in Cheshire and Merseyside, we currently have 2 trusts that have gone live with the service. So we've got Liverpool University Hospital that went live in August last year, and that was followed by Mid Cheshire Hospital December. And the reason we're all here, Wirral University Teaching Hospital is due to go live on Monday. So it is very important that for those pharmacies that are registered, they are service ready, and you know, so that referrals can be actioned in a timely manner. And we're currently working with other trusts, which are shown in amber, who are working towards implementing the service. The trust in red, they have not yet engaged with us. Could I have the next slide, please? And currently on the Wirral, I believe there's about 25 pharmacies registered to provide the service. I'm sure Adam and Gary will correct me if I'm wrong, but this information is taken from our website, and we currently have a good dashboard that provides an overview of trust status and also pharmacy registrations. So if you've not visited our website, highly recommended you do so. It is just a guide, and there's also a guide there on how to interpret the dashboard. Could I have the next slide, please? So here's some useful references. And the third link there is to our dashboard that I've just mentioned. And I think that brings me to the end of my presentation. Thank you for listening.
It does indeed. Thank you for that, Jan. Just to add into what you were saying around the maps, there's latest versions of the maps on the CPCW website. We keep them updated every week. So if you're on there and you're looking to see which pharmacies take part, if you hover over NHS contract and local support for NHS services, you can get to the latest maps for Cheshire, Wirral and Warrington. And I think the other LPCs, if you're looking at adjoining areas, I think the other LPCs have something similar. So if I can hand over now to Saf, if Saf you're able to turn camera and microphone on. Saf's coming from ABL and he's going to talk us through the detail of the service on the Wirral and the journey into a pharmacy. So I'll hand over to you now, Saf.
Thank you. Hi everyone, I'm Safwal Sadin. I'm a tobacco dependency practitioner from ABL Health Wirral Stop Smoking Service. I'm based at Arrow Park Hospital and my role involves developing and delivering the tobacco dependency program for secondary care. Next slide, please. Yeah. So just a quick overview of how the secondary care tobacco dependency service has developed over the year. Take you back first to 2007. That's when the electronic referral started from Arrow Park Hospital to local Wirral Stop Smoking Service. The beginning, it was a part-time service, and over the years, it has developed immensely. In fact, Wirral University Teaching Hospital was one of the leading secondary care trusts in establishing strong relationships and links with the locally commissioned Stop Smoking Service. In 2016, ABL Health was commissioned to deliver the Stop Smoking Service in Wirral, and it coincided with the Wirral University Teaching Hospital reviewing and relaunching their smoke-free policy. So there was a joint drive from both Arrow Park Hospital and ABL to develop this service. So a full-time hospital-based ABL tobacco dependency practitioner was appointed. The bedside tobacco treatment support program was started. A lot of work around developing the electronic referral system and the treatment pathways. An automated opt-out referral system was introduced. Also, a PGD for NRT was introduced because the aim was to increase the pool of staff who could prescribe NRT and not only limit it to doctors. So, and qualified nurses who had the training on the PGD can supply NRT, and to ensure NRT is kept at ward level so that to ensure it is given to patients as quickly as possible. Part of my role also involves delivering training to hospital staff, nursing staff, clinical support workers, and the junior doctors. Regular training sessions are organized for the junior doctors. Every year, the new cohort of F1 doctors, when they join the trust in summer, they get training on smoking cessation as well. Also, part of my work is to support the staff, helping them to quit smoking themselves. So you can see from the dates, we at Wirral, we were well ahead of any pilot cure program implemented in secondary care. Next slide, please. Yeah, thank you. So this slide sums up the client journey. We refer to patients as clients because they're a client of our service. So when patients get admitted to hospital, they get screened and asked whether they smoke or not, if they are identified as smokers. So this is recorded on their hospital record, and staff give them brief intervention and advise them that this is a smoke-free policy. NRT is prescribed for them at the same time. An automated opt-out referral is sent electronically directly to the hospital-based tobacco dependency practitioner. And the client is reviewed during their hospital stay by the tobacco dependency practitioner. They get assessed for their readiness, review their NRT use, make sure that they are using it effectively, suitably, and if any side effects, if any need to change the NRT, introduce different products. So all this managed by the tobacco dependency practitioner. Also, discussion is had with the clients about their plans, whether to continue with their quit attempt or they wish just to abstain from smoking during the hospital stay. Discussion around linking their health condition or reason of admission to smoking, and help them to see how by quitting smoking they could recover faster and manage their condition more efficiently. That patients also get reviewed multiple times during their hospital stay in preparation for discharge, because this is the crucial time, discharge planning, because if without a clear plan, most likely those clients who abstain in hospital without any follow-up, they will soon go back to smoking. So this is the crucial stage. So before the patient is discharged, they have a clear plan, they have an appointment booked with the stop smoking advisor, obviously for those who have opted to get ongoing support to quit, and ensure that they have at least 1 week of NRT and their discharge medication. What I also do, the day after they are discharged, I give them a quick phone call just to check that they have their NRT and discharge, because sometimes, some rare occasions, they either leave very quickly or they don't collect their discharge medication. So actually I work out with them how many days supply they have, work out whether they have enough until their next appointment. If it's not, then I will arrange for nicotine replacement product to be sent out to them or bring forward their follow-up appointment. It's just to ensure they don't run out discharge. Now, the follow-up in the communities, they get a weekly follow-up up to 12 weeks, including the supply of nicotine replacement products or vapes, if that's their choice. And the supply through ABL is direct supply and free of charge. Appointments in the community, they could have a choice between face-to-face telephone support or home visits if need be. After the end of the 12-week program, they get a follow-up call at 26 and 52 weeks for follow-up. Next slide, please. So around 40.5 to 57% of patients who were supported to quit smoking during hospital stay opt to have ongoing support after discharge. And we have an excellent 4-week quit rate at 67%. And at ABL, we pride ourselves of having a very low loss to follow-up rate of just 5%. Next slide, please. Okay, so this slide shows the new pathway. How now, with the introduction of the pharmacy service support, how things gonna work on discharge. So during the hospital stay, the patient is supported by an ABL specialist tobacco dependency practitioner. And those who opt to get ongoing support after discharge have that discussion with them about their choice of follow-up, either to stay with ABL or go to a local pharmacy. Obviously, it is the client's choice, but it is guided by a few factors. So if the client wishes to use a vape as their method of quitting after discharge, then these patients would need to be referred to ABL, because ABL provides vape kits and refills. If the client is assessed to be likely to require more than 12-week support for complex needs, and then these patients are to be referred to ABL. If a client had more than one supported quit attempt in the last 12 months, then this client might likely need specialist support, so they are being referred to ABL. If the patient has severe mental health conditions, so obviously they would need extensive and more intensive support. So those group of patients are referred to ABL for ongoing support after discharge. If the patient has substance misuse issues, those patients are usually have very strong links with their local pharmacies, almost daily contact with their local pharmacies. So if they wish to go to pharmacy, then that's maybe the best option for them. One of the key factors to determine if they can go to a pharmacy is if they are able to collect an RT from a community pharmacy. So community pharmacy doesn't send them out in the post for them if they don't attend. So to make sure that if they are able, then that's the choice for them. So basically this sums up the new pathway on discharge. And this brings to the end of my presentation, and thanks for listening.
Brill, thanks a lot for running through that for us, Saf. Obviously, if you've got any questions, as I say, use the Q&A function or hold them to the end and we'll invite them in at that point. At this point, I'll bring in Gary to talk about the PharmOutcomes module and the support.
Okay, thanks, Adam. I'm Gary, one of the two service managers from Community Pharmacy Cheshire and Wirral. I cover Warrington and Wirral. So if you do find you've got any questions once you start using this service or any of the others for that matter, please do feel free to get in touch. We are available to support. So, and tonight I've come to talk about the IT part of the pathway, I guess, PharmOutcomes, which is what we'll be using for referrals from WUTH. If we can go on to the next slide, fabulous. So the key thing to remember is, as Jan said, the service absolutely must always start with a referral from the hospital. So it's not something that can be triggered by a GP or a walk-in request. The referral has to come in that official capacity. And on Wirral, it is PharmOutcomes that we're going to be using. And this platform is set up, we'll look at it in more detail coming up shortly, but it's got the facility to handle all the data and the information that we need. And then, as Saf showed us in that pathway, once the patient is discharged, if community pharmacy is the chosen path, then that information can come across in that need solution in that referral. Next slide, please. So, as we can see, there are several options for that nationally, but as I say, locally, we're using the PharmOutcomes method, which is the neatest one. So as that referral comes in, it goes into some pre-populated PharmOutcomes modules, which we'll look at shortly. And again, as is the case with PharmOutcomes, it automatically sends that required data to the trust and the GP practice at set intervals as well. So there's no need for any printing off and posting or anything like that. It's all built in. At the moment, the actual claims for the remuneration for the service need to be manually input onto the MYS portal. That may change going forward as the provider pay model comes in, when there'll be the option for that API to send that claim across automatically, but we're not quite there yet. And, it's something you'll need to consider when that moment comes, and we'll revisit that again shortly. Next one, please. So every pharmacist that's signed up to deliver the service should have access to these templates. So you'll access them via the usual route in the left-hand column of the services tab of PharmOutcomes. And within that smoking cessation section is a set of linked templates that come through from that referral. So the first one being the intervention template. This is the one for the receipt of the referral, and then we've got interim appointment templates for the weekly ones with specific ones to record that 4 and 12 week quit as well. So it's all on there, easy to follow through, and also built within that is an onward referral mechanism should you need to forward on that referral to another pharmacy. So in a situation, for example, where a patient might be moving home, or they might be going into some sort of care facility that's not local, or the referral went to the wrong branch by accident in the first place, that sort of thing. Next, please. So as I said, the initial use of the template is free of charge. And at the moment, you do need to transfer the information across onto the MYS. There is a report you can run that will give you that information. We'll look at that shortly. But as time goes on, you'll have seen the move towards provider pays with the CPCS. So for pennies on the pound, there's the facility for it to do the automatic claim management. Next, please. So once that provider pays model comes along, you'll be given plenty notice of it, and you can decide whether you want to stay with the free option or you want to go onto that model. And it is in the pipeline. Hopefully it won't be too long. And again, there's the facility to join the affinity groups in the same way that there was with the CPS. So you'll get preferential rates on that also. And next, please. There are several resources that you can use if you want to be walked through the actual PharmOutcomes process. So that link that you've got there will take you to a presentation that was done in Liverpool, and it's timestamped. So that link will take you directly to the point where it's got the PharmOutcomes walkthrough. There's also a good video. It's about 15 minutes long, but it's worth a watch on the Pinnacle website. And if anybody would like that, then please get in touch and I can share the link to that as well. And then within PharmOutcomes, we've got access to several guides. They're all under the Contact Us section, and the Smoking Cessation Client Progress Guide can be used to generate the information you need for your NYS claim at the end of the month. And that really is all there is to it on that one. So I shall hand you back over to Adam. Thank you.
Brilliant, thanks a lot, Gary. And I think it should be said that Smoking Cessation Client Progress Guide, that's really helpful for when people want the information. The crucial thing is for pharmacies that use PharmOutcomes, the data provision that they need to send in is all covered within it. So if a trust wants to see it, they can log into their PharmOutcomes and see it live, or the ABL it would be in this instance. Or if the GPs want to see it, actually they get patient level reports as the provisions happen. So that's really important and really useful from that point of view. Obviously, if you've got your own solution and you choose to go down that route, then that you'll have to manage the data solution with whatever that looks like. That's about it for the scripted or the presentation elements of it. So for those of you that are on the call live, if you've got any questions and answers, please go ahead and put them in. There's no questions in there at the moment. If there's nothing in there for a minute or so, then I'll go ahead and close it down and we'll let you get on with your evening and enjoy the weather. So if you've got a really long question and you don't want to type it out, you can raise your hand and we'll invite you to speak as well if you want to do it that way.
Adam, is it worth us mentioning just that the slides and the recording will be hosted on the website if anybody wants to refer to them at some point in the
Yes.
Any colleagues?
Yeah, that's right. So the PDFs of the slides will be up, and we'll also have this video linked through to YouTube so anyone can use it. And if you've got colleagues in branches, then you're very welcome to do that. Steve, I notice you've put your hand up if you want to come in.
Yes, thank you. Really just to provide some additional information. So as we've said all the way through this, at this point, the only provision that can come from a community pharmacy is NRT. Jan mentioned that the NCSCT treatment programme includes support for people who choose vaping, e-cigarettes. That's true. We're hopeful, pardon me, I've got a bit of a tickle in my throat this evening. We're hopeful that actually NRT, sorry, I beg your pardon, vapes will be able to be provided by the pharmacy service in the not too distant future. And the same is also true for a couple of prescription-only medicines. The first of those is varenicline. Now, obviously, we're all aware that Pfizer withdrew Champix some little while ago. What you may or may not have be aware of is that there are moves afoot to reintroduce varenicline onto the UK market. What we can tell you at this point is it's not the Pfizer branded product, but we expect before the end of this calendar year, hopefully not too distant future, that 1 or 2 generic manufacturers will actually get a license for varenicline product in the UK market. And there is potential that might also apply to cytosine. Obviously, at the moment, products are unlicensed, which means that they can't be provided under a PGD. But once there are licensed products available, then PGDs will be developed. And in fact, there is already a national PGD template for varenicline if local areas don't have an existing one for Champix that they could adapt and bring it up to date. But certainly those 3 modalities will be incorporated into the offer from community pharmacies basically as soon as they're available. Obviously, locally, there might be a little bit of a time lag whilst the appropriate PGDs are put in place, etc. But those options will be available, hopefully all of them, or certainly 3 of them, before the end of this NHS financial year. But it's sort of in the lap of the gods to some degree, but there is a lot of work going on in the background to ensure that that can be brought into the service as soon as possible.
Well, that's really helpful bit of feature gazing, Steve. Thank you. I think one of the things that we're quite lucky in Cheshire and Mersey of the 9 areas or 9 places, I think we had 4 varenicline PGDs across those 9 areas. So there's expertise locally in delivering and developing them. So I'm sure the areas that didn't have one will be able to tap in should they want to. So
yes.
We'll be able to work together to do that. That will be good.
Sure.
Brill. Well, I've got no questions and no hands up, so I'm going to bring this to a close. Thank you very much to all our presenters for presenting tonight and for distilling their information. That's been hugely helpful, and I think we've created a really useful resource as we go through for contractors on the Wirral or surrounding areas who want to be a part of delivering this really useful service for patients. So thank you everyone. Thank you everyone for presenting. Thank you everyone for attending. If you do have any questions or you think of anything after the event, just send them through to support@cpcw.org.uk and we'll make sure we answer you quickly there.